Hi everyone, my name's Ash and I'm a current PhD candidate from the University of South Australia. Today I'll be presenting on our recent study which looks at the development of an actinium-based radionuclide therapy for pancreatic cancer. So before I start, I would just like to acknowledge my co-authors listed on the slide here, as well as Pankind, the ANZ S&M and ANSTO, who each provided financial support for this project to go ahead. So as you may be aware, pancreatic cancer is a highly aggressive malignancy, with a current 5-year survival rate of only 10% in Australia. There have been only minor improvements in this survival across recent decades. At the moment, surgery is the only curative treatment option available for these patients. However, its application is restricted to patients with locally resectable disease, and often this is only in about 10 to 20% of patients at diagnosis. For those patients ineligible for surgery, the first-line treatment is typically chemotherapy, and this can be prescribed with or without the addition of external beam radiation therapy. Now, whilst this chemoradiation can help to prolong patient survival, it's not considered curative. And as over 80% of patients presenting with pancreatic cancer may go to this chemoradiation, it's highlighting a real need to invest more in therapies that have a better capacity for targeting metastatic spread of pancreatic cancer. Now, targeted radionuclide therapy is one possible therapeutic approach which could help to improve the systemic control of pancreatic cancer. So we'd all probably be quite familiar with radionuclide therapy in that it's a molecular-based form of radiation therapy which is aiming to deliver cytotoxic radiation doses directly to our cancerous cells whilst aiming to spare normal cells. In our work, we're specifically interested in looking at radioimmunotherapies. So this is where we have an antibody or an antibody fragment and bind that to a therapeutic radionuclide to perform a radioimmunoconjugate, and that conjugate is then designed to target a certain epitope which is overexpressed by the cancerous cells ideally and also has minimal expression by normal cells. In the work in this study, we're aiming to target mucin-1. So mucin-1 is a transmembrane protein which is normally expressed on the apical surface of our epithelial tissues. It usually has a role in anti-adhesion properties and assisting in cell signalling. But the region we're particularly interested in for our work is this variable number tandem repeat region. So in normal MUC1, this area is heavily glycosylated. However, as tissues transform into cancerous forms, that variable number tandem repeat region becomes hypoglycosylated. And as it loses some of that glycosylation, it reveals a number of novel epitopes, which can only be targeted when we have the low level of glycosylation, so they can be considered as cancer-specific epitopes. Our work specifically is interested in targeting the RPAP epitope, so that's available within this variable number tandem repeat region. And our previous work has confirmed that that region is targeted by the C595 antibody. So the C595 antibody is our targeting vector for our radioimmunotherapy approach. Now, there are a number of therapeutic radionuclides which can be used for targeted radionuclide therapy. Currently, beta emitters such as lutetium-177 are more widely used within Australia. However, we are particularly interested in looking at actinium-225. So actinium is an alpha emitter, and as an alpha emitter, it releases the alpha particles, and these alpha particles have some promising physical properties that could potentially make them superior to beta particles. So with alpha particles, they have quite a short range, but a high energy compared to the beta particles. This gives them a high linear energy transfer. And essentially this means that they can cause more dense ionization of the DNA strand, as you can see in the image down the bottom. The more ionization events we have within the DNA strand, the more likely we are to cause double-strand DNA breaks, which could then lead to cell death. So for these reasons, our work has looked most specifically at actinium-225 for now. So the aim of this study was to establish the feasibility of using an actinium-DOTA-C595 radioimmunoconjugate for pancreatic cancer. So to begin with, we performed some radiolabeling. So in this study, we used actinium-225, which was sourced from Oak Ridge National Laboratory in the USA. This was bound to about 700 micrograms of DOTA-C595, and the two were incubated in an ammonium acetate buffer for 1 hour at 37 degrees. After that time, they were then monitored using instant thin layer chromatography. If that ITLC result was below 95%, we could then perform an additional purification step as needed before progressing with our experiments. Initially, we performed a cell binding assay. So in this assay, we incubated 4 different pancreatic cancer cells with varying concentrations of the actinium DOTA-C595. They were incubated for 1 hour at 37 degrees. After that time, unbound activity was removed, the cells were washed, and then they were detached from the well plate, and the collected cell samples were then measured using a gamma counter to determine the counts across the different concentrations for each pancreatic cancer cell line. So as I mentioned, we had 4 pancreatic cancer cell lines, and these varied in their expression of MUC1. So we've previously quantified the percentage of cells which have positive MUC1 expression for each of these cell lines. So PANC1 has about 93% of MUC1 positive cells within its sampling, and then that goes down to only 11.5% for the ASPC1 cells. So we aim to get a good snapshot of pancreatic cancer cells with high MUC1 expression all the way down to weak expression. So from the cell binding experiment, we were able to ascertain that binding to PANC1 cells was significantly greater than the other cell lines at concentrations of 50 nanomoles and above for the actinium DOTA-C595. And given that the PANC1 cell line has that higher MUC1 expression, this is exactly what we were looking to see in seeing that there is preferential binding to the cells with the highest MUC1 expression. So we then moved on to evaluate the internalisation of our radioimmunoconjugate. So in this experiment, we had the same 4 cell lines, which were incubated with a fixed concentration of our radioimmunoconjugate. They were then monitored for 1 to 48 hours. And at different time points, we removed the supernatant and then washed the cells. We could then strip the surface-bound activity using an acidic wash. And then after that was removed, we could then collect the internalised activity by lysing the cells. We would then count both the surface and the internalised fractions of the cells separately, and this allowed us to evaluate how much of the radioimmunoconjugate was being taken into the cells and how that internalisation rate differed over the 48-hour period. So these graphs demonstrate the results of that internalisation experiment. So again, we can see that PANC1 had both the highest surface counts and internal counts across all the time points and all the cell lines. So again, this is as expected, giving its strong MUC1 expression. So perhaps most important is the percentage of internalisation, where we can see how that internalisation rate changes over time. So initially, at the 1 hour time point, we can see that PANC1 has internalised about 18% of the radioimmunoconjugate, whilst all the other cells are more around the 10% range. The PANC1 internalisation then increases to a maximum of about 50% by 48 hours. So that is quite a rapid increase in internalisation. We can also see that ASPC1 demonstrated similar internalisation patterns to PANC1, and that's interesting as ASPC has the lowest amount of MUC1 expression. However, it is comparing the rate of surface-bound counts to the internal count, so it can still be normalised to the number of MUC1 receptors as well. But what was important was that we were seeing a level of internalisation across all of the cell lines, which did typically increase as time increased as well. As we'd confirmed that our radioimmunoconjugate had good binding to the MUC1 positive cell lines and good internalisation, we then were interested to start looking at some of the potential cytotoxicity of the conjugate, as obviously for a therapeutic conjugate we want to make sure that it has the capability to actually induce cell death. So we've elected to look at the gamma H2AX foci. So gamma H2AX or H2AX is a marker of double-strand DNA breaks, and often if unrepaired, double-strand DNA breaks can lead to cell death. So this is designed to give us an indication of how well it can induce potential double-strand DNA breaks which are likely to lead to that cell death. So in this experiment, the cells were treated with fixed concentrations of the actinium DOTA-C595 for 1 hour, 24 hours, and 48 hours. We also had some untreated controls and cells treated with just cold DOTA-C595. And after each of the time points, the cells were stained for the gamma H2AX antibody, and then they were analysed using flow cytometry. So we have a number of data from this study, but I've elected just to focus on the PANC1 cell lines across the 3 different time points for today, just for simplicity. So at the 1 hour time point, we can see that straight away there is pretty much all of the PANC1 cells have some level of gamma H2AX foci within their sample. So this is indicating quite an impressive killing power, or damaging power, I should say, of the actinium conjugate within 1 hour. This level of damage then remains at the same level to the decimal point at the 24-hour mark for the PANC1 cell lines again. So again, we're still seeing that those double-strand DNA breaks are progressing for that 24 hours. However, by 48 hours, we can see that the percentage of positive PANC1 cells, or cells that are positive for the gamma H2AX focus, has decreased ever so slightly to 98.31%. But what you may also notice is that the peak has changed, and that has shifted down quite significantly. And so we are speculating that that might actually be due to the PANC1 cells exhibiting cell death by the 48-hour time point. However, this is still just speculation. We can't confirm that at the moment, but we're hoping to look into this a bit further. But essentially, these results are showing that there is definitely a damaging effect caused by the actinium conjugate. Okay, so to conclude the presentation, we saw today that the cell binding and internalization using the actinium DOTA-C595 was preferential to cells with a high MUC1 expression. We also saw that we were able to induce gamma H2AX foci in cells that were treated with our radioimmunoconjugate. And all of these studies are supportive of actinium DOTA-C595 as a possible radioimmunotherapy approach for pancreatic cancer, but specifically for pancreatic cancers that express the mucin-1 cancer-specific epitope. We're aiming to continue to progress this research further by continuing to confirm the in vitro cytotoxicity. And then if these are positive, we would like to progress to animal studies, which are subject to funding. So I would just like to again acknowledge both PanKind and the ANSTO and ANZSNM who financially supported this study. These are just the references, and thank you for listening. If you have any questions, feel free to send an email my way.